During public health crises such as pandemics, resource allocation often shift from a logic of meeting the individual patient's needs and interests regardless of the cost, to a more utilitarian logic that would maximize the good for the greatest number of people. And that utilitarian logic generally endeavors to remain egalitarian in that it applies all rules to everyone equally. But that equality might be formalistic rather than substantial if some rules systematically penalize a certain population and or do so in a way that is not morally justified. In the early months of the COVID-19 pandemic, a number of critical care guidelines and protocols were drafted around the world and prompted criticisms from groups representing the interests of older adults and disabled people around the world. Bioethicist Jackie Leach Scully, for instance, suggested that some disableist assumptions about the overall health of people with disabilities, about their quality of life, and about their social utility might find their way into triage policies. Legal theorist Deborah Hellman looked at utilitarian standards used to distribute limited life-saving medical resources, such as ventilators, standards such as probability of benefit, efficiency, life expectancy, and quality of life. And she explained how they could disproportionately affect people with disabilities in a way that didn't balance utility with equity the way discrimination law demands. Here in Canada, various disability organizations were concerned about the relative lack of transparency of triage protocols, some of which on their face violated the rights of people with disability to equal protection and equal benefit of the law without discrimination, as well as their rights to security and life. This was especially problematic when the protocols identified specific disabilities, such as severe cognitive impairments, as corresponding to a lower priority score. Various lawsuits were launched in the US and Canada. Disability organizations mostly launched petitions here in Canada and wrote letters to provincial health ministers and were in great part successful. They asked, for instance, that the exclusion criteria referring to specific handicaps be removed from protocols, that clinical evaluation tools relating to functional autonomy not be used to exclude a patient from intensive care, that protocols include explicit statements against discriminatory prejudices on the value of a disabled person's life during the triage process, that persons with disabilities and their representatives can participate in the revision of the protocol, and that health departments be more transparent about the triage process. So these recent developments made it clear that bioethics and egalitarian politics are still in need of incorporating a robust understanding of the ethics of disability to help our policymakers. So it's my pleasure to introduce our main speaker, Professor Laura Guidry-Grimes, who will discuss the theoretical foundations of disability rights during a public health crisis from the vantage point of a US-based clinical ethicist and philosopher with a specialization in disability bioethics. Laura Guidry-Grimes, I hope I'm pronouncing your name correctly, is an assistant professor in bioethics and medical humanities at the University of Arkansas for Medical Sciences, and she serves as a clinical ethicist for the Health in Arkansas Children's Hospital. Dr. Guidry-Grimes received her doctorate in philosophy at Georgetown University and previously worked at MedStar Washington Hospital Center in Washington, D.C. She's interested in disability bioethics, psychiatric ethics, and determining how best to understand vulnerability in healthcare. I myself am Jonas Beaudry. I work here at McGill at the IHSP and the law faculty. So now I'm going to pass it over to turn it over to Dr. Guidry-Grimes.
Thank you so much for having me and for showing up for this talk. I'm really excited for this conversation. I'm really honored to be here. And the last name was very close, but it's Guidry-Grimes. We butcher it in the US based on its French roots. So anyway, I will share my screen now. All right, successful. Yes, I don't take anything for granted with technology anymore. All right, so I am, as Dr. Beaudry said, a philosopher and clinical ethicist by training. And so clinical ethics, you know, I don't know how many folks are familiar, but the idea here is that I do have a substantial portion of my position that is dedicated to clinical spaces. So I round with clinical teams and provide an ethics perspective on different patients. I provide consultation when cases bring up certain ambiguities or concerns or questions or even conflicts when it comes to the ethical issues at stake. I work on policy. I've led policy review and development for 7 years now, and do ethics education around the hospital. And my background really is more hospital-based rather than outpatient-based. But just to clarify sort of my background, I'm excited to hear what your perspective is from your backgrounds on this issue. And there's a QR code here. If you take your smartphone and hover over the grid, you'll get a prompt to go to a link. This talk that I'm giving was inspired by a paper that I co-authored with a group of fantastic folks that you can see there, that was published in the Hastings Center report, Disability Rights as a Necessary Framework for Crisis Standards of Care and the Future of Healthcare. And it's open access, so yay. All right, so my presentation has 4 sections, which might sound like a lot. I'll definitely keep an eye on the clock so that we have plenty of time to discuss. So first I want to go over just the basics of public health emergencies, and I apologize if the folks listening in are very, very, very familiar with everything I'm going to say, but I figure it's helpful to give the backdrop in which we're having this conversation. And then I'm going to talk about the lens of disability, bioethics, and conceptions of justice, and then bringing it all together, protecting disability rights in a pandemic. At that point, I'm going to just pause so that we can talk and discuss. My 4th section is really meant to be more interactive. I have a couple of policy examples for us to discuss. One is a particularly horrendous case that happened in the United States, and then also the topic of triage policy. All right, so as I mentioned, there are QR codes. The medium I'm using for interaction is called Mentimeter. It's a free website, and so that, again, that's in that 4th section, where it's supposed to facilitate audience engagement in a more fun way than just Zoom chat. So, but feel free to use Zoom chat as much as you wish. All right, so the basics of public health emergency. As Dr. Beaudry said, that when we talk about the usual standard of care, we're talking about patient-centered decision-making. And as I'll talk about, that's also the aim with contingency standards of care. But here we have fidelity to the individual patient and respect for the rights and preferences of patients as really central to what we're aiming for ethically. However, when we have a shift into a public health emergency and a true crisis, then we have a shift from more patient-centered to more community-centered decision-making. Right, so this is promoting public safety, protecting community health, and fairly allocating dwindling resources. And this emergency could happen sort of gradually. It could be prolonged, as what we're seeing in the pandemic. But I mean, it can also be very sudden. So for example, when Hurricane Katrina devastated Louisiana, that led to its own public health emergency and crisis standards and very, very quick thinking and response. And there are universal ethical considerations across this spectrum. So things like care, privacy, transparency, fairness, accountability, and relief of suffering. There are plenty of ethical norms that supervene, even if we're in an emergency or normal standards of care. And so this is, I think, a helpful diagram from the Institute of Medicine, now called the National Academy of Medicine. from their seminal text, Crisis Standards of Care, from 2012. So they are really looking at like flu, H1N1 as sort of their model virus for what a pandemic could look like that could lead to potentially crisis standards of care. And so these were sort of general guidelines taking into account the duty to plan. And so what this shows is that as far as the scarce resources that are at stake, we're talking about space, staff, and supplies. In the general media, at least in the United States, there's a heavy focus on supplies and particular supplies, but all of this can be an enormous issue. And in fact, we've seen this in this pandemic, that ICU space can be a big problem. Negative pressure rooms can go scarce real quick. And we've had great strain on staff and the great resignation globally. And so we have fewer and fewer staff to be able to provide the care. And even when it comes to ventilators, we need specialists to help with ventilatory support. If we're talking about ECMO, we need to have ECMO technicians providing around the clock care when someone's hooked up to ECMO. So staff can be an enormous issue as well. And so when we move from conventional standards, right, this is usual care, and move into contingency and crisis, what happens is the incident demand / resource imbalance is increasing, and the risk of morbidity and mortality to the patient increases. And so we go from usual care to potential crisis care, but it goes into contingency care. So the idea with contingency care is we're trying to prevent crisis standards of care, but at the same time, the system is strained. The system has certain cracks that arrive, and those kinds of systemic strains, especially in a prolonged pandemic, can definitely have lots of effects for patients as well as families and healthcare professionals. And I'll talk a little bit about that. And then, of course, the nightmare scenario is the crisis standards of care. We all want to avoid crisis standards of care. I had medical students early in 2020 who were under the impression that like all hospitals had jumped to crisis standards of care. That's not true. You know, in the United States at this point, a handful of places have enacted crisis standards of care, but for the most part, a lot of hospital systems and entire states have been able to avoid crisis standards, but we've seen prolonged contingency standards of care. And most of the focus, right, I mean, even the name of this document is Crisis Standards of Care. And when you look at so many of the things that were published, they're really focused on crisis standards of care. And this idea that contingency standards of care are functionally equivalent, I think we've learned over the last 2 years is a dangerous notion. We know the ways in which it's really not functionally equivalent, and I'll get to that as well. So this is a diagram I made to try to condense many pages of text from here. So when we talk about the resources and how the need for resources increasingly outstrip actual availability, you go from conservation mode and conventional or contingency standards to substitution and adaptation, right? So for example, one of the things that was explored is whether one ventilator could be used for 2 patients, whether an ICU ventilator could be adapted in that way. In the course of this pandemic, we've also seen guidelines come out from the FDA, the US FDA, on how to adapt personal ventilators, home ventilators for ICU purposes. And so there we're starting to swing more into contingency and potentially into crisis, and then reusing resources. So when you have, for example, staff who are reusing single-use masks, right, because there aren't enough masks, that's a sign that we're in contingency or crisis mode. And then reallocation is something we all want to avoid, and that's really what the IOM, now NAM, really describes as being within the realm of true crisis standards of care. So for example, right, the ventilator is the classic example. If you've allocated a ventilator to a particular patient, we'll say patient A, and it turns out that patient B down the line could potentially get greater benefit, then there's the question of whether you should remove the ventilator from patient A for the sake of reallocating to patient B. And that goes against everything that we think of in terms of patient-centered care, because presumably if that patient A is dependent on that ventilator, then they're now in a dangerous situation, life-limiting situation, they might die immediately kind of situation. So reallocation is the nightmare of the nightmare kind of situation with a crisis. And there are lots and lots of ethical issues that affect patient care in a pandemic. As I'm sure you all know, right, there's discharge and congregate care questions, limiting hospital and facility visitors. From someone who works in hospitals, I'll say the visitation restrictions has been one of the biggest issues. That has been like day-to-day moral distress for healthcare professionals, and all sorts of tragedies when it comes to patients dying alone, families not being adequately informed, and just a whole host of everyday issues. The first couple of weeks of the pandemic, I was a screener, and had a family member threaten to punch me if I didn't let him see his daughter after she had just had surgery. Like, I understood his distress, right? His daughter had just had surgery, right? But that kind of thing is happening pretty frequently, that people are understandably distressed. And of course, resource allocation, but also limiting CPR, right? To what extent, especially with an infection that's aerosolizing, in other words, during a CPR procedure, if it's thought that you're going to get more COVID into the air and put healthcare workers at greater risk, then is there a point where you should limit CPR, or maybe all healthcare professionals can don all PPE, even if it slows down their response by, a minute before they get into the room, and that means lower chance of survival, perhaps, for the patient, right? How should you balance all of that? Patient isolation and quarantine are, of course, big issues. Some hospitals are set up for pretty successful patient isolation and quarantine when they need to. Other hospitals have really struggled with that. Patients who have behavioral disturbances or who are in psychiatric crisis, some hospitals really are not equipped to deal with that in the course of a pandemic if they also need to be quarantined. And canceling elective procedures, where elective doesn't mean like completely unnecessary and purely, like luxurious therapies or treatments or something, right? Where elective just means it's not immediately expected to be necessary for that patient. So you have all sorts of elective procedures that are actually important for people's health that have been postponed repeatedly. That's just some of many issues. And so part of what I want to emphasize, even though we're going to be talking a little bit about ventilators today, is it's not all about ventilators. And I think, again, something we've learned since 2020 is that the over focus on ventilator allocation means that other ethical issues, ones that are actually more likely to be issues in this pandemic, can be neglected or otherwise given insufficient attention by healthcare systems and the general public. So lots of hospitals that had to go into crisis standards in this country, what I've heard from other clinical ethicists is it ended up not being about ventilators at the end of the day. It was about like pain medications, dialysis machines. ECMO was a big scary moment, and that moment seems to have passed a bit. But so we focused so much on ventilators that we weren't paying attention to everything we should have. And so I mentioned contingency standards and how there hasn't really been sufficient attention to contingency standards going back a decade and up through leading up to the pandemic, and even during the pandemic, there's shockingly little written on it. And so as I mentioned, patient-centered care is still supposed to be the central goal when we're in this middle limbo state between normal care and crisis standards. But I think this is written well by these bioethicists out of the UK. They say, however, in situations where patient-centered, functionally equivalent care either cannot be achieved, or what counts as functionally equivalent care is contested, for example, it is equivalent in one respect, but not in others, that the interesting, arguably distinctive ethical issues and dilemmas arise. To expand on that a bit further, if we look at, well, what gets chipped away during contingency standards? And, again, if contingency standards are lasting a few months, that might be one thing that can be handled more easily. But part of the problem with the prolonged pandemic is what is sustainable, given that humans are humans and systems are going to break down more and more over time, the more that they're strained. So what gets chipped away? So something that's mentioned by these same bioethicists in the UK is the care part of healthcare, of patient-centered care, that gets chipped away because the interpersonal relationships are now mediated through, sometimes many layers of PPE. You have strained and more limited staff, and the visitation restrictions can also mean that patients are alone without opportunities to share in decisions with their family members and even healthcare professionals as much, where you really have the human element of healthcare not looking at all the same in a pandemic. And I could give many, many anecdotes in this regard. I think this is a common observation. And equity as well. So we think of equity as being primarily an issue with crisis standards of care, but it really is an issue with contingency standards as well. So this is care for patients with COVID-19 and those without it, right? How do we balance those two patient populations has turned out to be a bigger issue, I think, than a lot of us thought beforehand. Care across institutions and regions, right? To what extent is there regional collaboration, cooperation on some of the big issues related to this pandemic? Regional guidelines were pretty late in the coming. And then care for those in need of elective services, as I mentioned. And so the question of who falls through the cracks of a cracked system, right? And the people who are going to fall through the crack are those who are already the most vulnerable to fall through cracks and experience the worst effects of a pandemic. And so bringing in disability bioethics, and disability bioethics is an area within bioethics. I won't go into all the definitional work that folks are working on, but the idea is to take a disability studies lens to bioethics, similar to how we would bring like feminist philosophy to bioethics to have feminist bioethics. And then looking at different conceptions of justice within that lens. And so again, this might be common knowledge to the folks who are zoomed in, but I wanted to go ahead and make sure that we have a common foundation. So the question of what does it mean to be disabled is answered differently according to lots of standard biomedical textbooks that are even used in medical colleges throughout the world, and what we learn from the insights of disability studies, which is a rich interdisciplinary field that's been around for decades. And so this is nicely said by Stephen Smith in Equality and Diversity. Impairment is associated with a particular medical condition, which may or may not lead to a disability, with the disability being associated with various social and political restrictions. So there's this sort of classic distinction between impairment and disability. It's an imperfect distinction, but the idea being that impairment is the thing in the body, perhaps, whereas disability may be more related to environmental features. If we ask what is disabling, we might actually be primarily looking outside the body. And so this was said in the Fundamental Principles of Disability back in 1976. Disability is the loss or limitation of opportunities to take part in the normal life of community on an equal level with others due to physical and social barriers. So again, that focus on what's disabling, physical and social barriers in the outside world. The World Health Organization says that disability is a complex phenomenon, reflecting the interaction between features of a person's body and features of the society in which he or she lives. Overcoming the difficulties faced by people with disabilities requires interventions to remove environmental and social barriers. Okay, so when disability is viewed purely as a biological entity, chemical entity, a genetic defect, when it's viewed in that way, one of the results of that is when we think of addressing disability, fixing disability, then it gets focused on doing things to people's bodies. And so the pushback from disability studies is to look at the social features of disability, the lived experiences and first-person reports of people with disabilities, and what they attest is actually disabling. And so I won't go through all this, but for example, the medical model would ask, like, what is wrong with you such that you have this disability or impairment? The social model asks, what is wrong with society? What social, economic, political, or environmental conditions need to be changed to facilitate the full enjoyment of all rights by all people with disabilities? Right, so this is from the Disability and Disableism website from the Council of Europe. And I'm happy to share my slides. There are some really great resources out there to help explain this shift in how we model disability. I want to bring in some data that were published. This particular article came from 2021. Lisa Iazoni and her colleagues have done some really fantastic work for years, looking at empirical data related to healthcare professionals and their understanding and relationship with disability as a concept and patients with disabilities. So in this one, she and her colleagues surveyed 714 practicing US physicians from 2019 to 2020. 36% of them reported knowing little or nothing about their legal obligations to persons with disabilities. So that's a nice depressing, this is a very depressing slide, I'm going to forewarn you. 50% reported having some knowledge. 71% of the physicians reported not knowing who determines reasonable accommodations for their patients with disabilities. More specifically, like, they did not understand that it requires collaboration between patients and clinicians. And I think it was like only 40% thought that patients would be part of the picture of helping to figure out reasonable accommodations. 41% reported feeling very confident about their ability to provide the same quality of care to their patients with disabilities compared to their non-disabled counterparts. Right, only 41%. So, I mean, part of what's disheartening about this is that we have decades of data that pretty much show the same kind of thing as far as the ableist biases, the disability discrimination, the lack of fundamental understanding of knowledge of how to care for patients with disabilities. And there are plenty of structural issues too, right? It's not all on any one individual to fix all the issues in medicine in this area. Plenty of it is institutional, structural, systemic, but these data should have us take pause. And so I love that Jackie Leach Scully was already mentioned. I love her work. And she has this fabulous article where she talks about vulnerability in relation to disability. And she brings out some helpful distinctions, borrowing from the work of some feminist bioethicists. She said, you know, when we think about vulnerability and disability, there's this error in commonly thinking that because someone has a disability that they're globally vulnerable, and that can be dangerous for all sorts of reasons, including certain paternalistic overtones of that. And so she says, you know, some disabilities might have inherent vulnerabilities that are directly the result of the impairment. So folks who have chronic pain or a long-term degenerative process, they can have vulnerabilities that are inherent to that, the pain, the long-term degenerative process. But lots and lots and lots of the vulnerabilities associated with disability are actually situational. Right? So these are due to patterns of social, cultural, and political response to impairment or other atypicality. And so again, this is where that social model of disability sheds light on what is disabling and in what ways are disabled persons vulnerable. And then she also brings out this notion of pathogenic vulnerability. This arises when interpersonal relationships or institutional structures exacerbate vulnerabilities. So a kind of classic example of this and disability studies is that cognitively impaired residents in nursing homes are susceptible to abuse and neglect by caregivers. In the pandemic, we also see that cognitively impaired residents, whether it's due to dementia or certain intellectual or developmental disabilities, that if their facility did not get adequate PPE allotments, and the people caring for them were not necessarily able to have PPE when caring for them all the time, or the facilities might not have been very strict about people wearing PPE or had good education on how to wear PPE. So all of that can lead to these pathogenic vulnerabilities. So I think a lot of these concepts are really helpful for sort of breaking down what happened in the pandemic and continues to happen. And there are, of course, a host of vulnerabilities in healthcare for disabled persons, even in non-pandemic times. The individual is often not empowered as a participant in decision-making for all sorts of reasons that are problematic. Life with disability is unfairly devalued. Again, Lisa Iazzoni and her colleagues and lots of others have studied the attitudes of physicians, nurses, and others when it comes to quality of life with disability. And those quality of life assumptions tend to be much lower than what persons with disabilities actually report. And choices are severely limited or constrained because of structural and systemic issues related to disability bias in medicine and outside of medicine. So this is by no means a comprehensive list, but again, just to get us all on the same page, that there are plenty of issues here that are not pandemic specific. And so something that my colleagues and I in that paper I mentioned highlight is the distinction and the marrying of distributive and recognitive justice, or distribution and recognition, if you prefer. So this is a neat sort of summary of this distinction. So recognition seeks to ensure equal respect for individuals to whom it has been denied, and redistribution seeks to correct unfair disparities in advances of various kinds or advantages. And so broadly, the idea here is that the social and political conditions for diverse people to have their needs met and to express their freedom, to pursue the good life, to live the life that they choose, especially within histories of oppression, right? Because we aren't in socio-political vacuums. The reality of that means that we have to go beyond distributive patterns. And of course, distributive justice matters in all this, but we can't assume that recognition, this idea of equal respect for diverse persons, is achieved through redistribution. All right, so this is, in a very sloppy nutshell, part of what people call like the welfare or charity problem approach to handling discrimination, is that having, services, funds redistributed in certain ways that has a certain kind of benefit potentially, but we need both of these kinds of justice to come together. And so to say a little bit more, because I assume that recognitive justice might be newer to a lot of folks as opposed to distributive justice, we ask, well, what needs to be recognized? The status of diverse groups as equal participants in social life, right? Easier said than done. The value of group difference and individual difference. The importance of self-identified needs and interests. Because otherwise we have harms of what Nancy Fraser calls harms of misrecognition and status subordination. And so the disability rights movement, right, their slogan of nothing about us without us, is really focused on this recognitive justice, that if you're going to make laws and policies, if you're going to make decisions on a small scale or a big scale about, or that largely affect people with disabilities, and yet they've been systematically excluded from all of that decision making, then they have not been respected as equal participants in social life. They have not been treated as partners, they've been treated as objects, that their forms of difference and their self-identified needs have not been properly taken into account. So Nancy Fraser says that recognition means deinstitutionalizing patterns of cultural value that impede parity of participation and replacing them with patterns that foster it. So this notion of recognitive justice and inclusion, how are decisions getting made, and how many smoke screens and how many paywalls and how many boardrooms with the closed door, how are these decisions being made and who all is being excluded? And of course, I'll flag that this is relevant to racial justice as well as disability justice. So bringing it all together, we talk about protecting disability rights in a pandemic. The first thing I'll say, since a lot of folks are, I assume, on this call are from a legal or policy background, is that from a legal, policy, as well as ethical and clinical standpoint, we need to have good data to understand how to protect disability rights. We need to understand the morbidity and mortality of different groups, outcomes from interventions, clinical risk factors, medical error rates, who actually has access to hospitalization, standard treatments and tests, as well as experimental therapeutics and vaccinations. And then other institutional and structural inequities and disadvantages. If we don't have the data, then it's very hard to make the right kind of argument and address the right kind of thing. But there is this trickiness when it comes to data and disability with COVID. On the one hand, it seems like we have lots of data, like in England, 58% of their deaths from COVID-19 were persons with disabilities by their own reports. But part of it is, again, the conception of disability being used. If we just extract from electronic medical records based on diagnoses or payer source, we're going to have some faulty ways of engineering disability for the sake of these data. And there's a recent article in Nature where this was called out, where when it comes to disability status infection, the dearth of data makes it hard to gauge the impact of COVID-19 on people with disabilities and to study the effects of legal and policy interventions. So we have like a study here and a study there, publication here, publication there. Like in the US, if I go to the Centers for Disease Control, they have all the updated information with specifics and trackers and trends and ways in which you can modify the bar graphs and everything, broken down according to age, race, sex, whether you're in a rural area, and you have underlying medical conditions. But again, underlying medical conditions is an imperfect proxy for disability. And so they do have pages on disability and equity and COVID-19. I found myself having to hunt for it a little bit because it wasn't in any of the obvious places I would expect when it comes to their mortality data. And it seems to be an issue outside the US too, but I'd be interested in what you all are seeing. And so, what puts persons with disabilities at higher risk in a pandemic? It could be one or many of these things. So underlying health conditions and long-term health inequities, right? Those can go together. Why there's a higher comorbidity burden in certain populations can be directly related to long-term inequities. Congregate care living, as Dr. Beaudry mentioned, right? Especially if there's inadequate PPE, inadequate staff, there aren't clear safety procedures for how to handle congregate care living, and things like psychiatric hospitals. Psychiatric hospitals are generally not built for things like, physical distancing, right? The part of the whole philosophy of psychiatric hospitals in 2022 anyway, is that patients should be interacting. That's part of the therapeutic space. And so that can be a significant problem. We saw lots of vulnerability in psychiatric hospitals or units. Physical distancing may be difficult to implement, for example, due to reliance on caregivers. Public health measures may be difficult to understand for those with neurocognitive, intellectual, or psychiatric disabilities, right? Hard to understand or hard to implement. Difficulty accessing care or vaccination. I'll talk a little bit about that as well. and not having support persons and skilled caregivers bedside. So early in the pandemic, at a lot of hospitals I'll say in the US because I don't want to speak globally, but visitation initially was very, very, very restrictive, right? Just no visitors except in very few circumstances. But some patients benefit a whole lot more from having people bedside than others. Like, for example, Evacate has written about the extreme stress when her daughter with an intellectual disability was hospitalized, because her daughter needs to have people who know her daughter bedside, who can provide the skilled care that's specialized to her daughter. And they didn't have that for a period when her daughter was in the hospital. And so that disproportionate impact of visitation policies we also saw. And of course, ableism. A lot of these lists don't even just say the word ableism. It's kind of like when you're talking about why there are disparities in health based on race or ethnic data, and nobody just says racism. It's weird. So anyway, ableism, of course, is also a big part of this. There are many, many studies out there looking at data related to disability and COVID, what can be gleaned. This is from the New England Journal of Medicine Catalyst, and they looked at the devastating impact of COVID-19 on individuals with intellectual disabilities in the United States. And what they found through this cross-sectional study of, let me see, it was, not all of these patients had intellectual disabilities, but let me see, I have the numbers in front of me. So over 128,000 were patients with intellectual disabilities of the study across 547 healthcare organizations. And they found in this ginormous study that COVID-19 has had a devastating impact. Having an intellectual disability was the strongest independent risk factor for presenting with a COVID-19 diagnosis, and the strongest independent risk factor other than age for COVID-19 mortality. Right, so this is huge when we think about preventive care, as well as how, what happened with persons with intellectual disabilities in the course of pandemic, and we're thinking about vaccines and the recovery period as well. We also found that ICU admissions were not elevated for this population, so they rightly raised the question whether there was some barrier to patients with intellectual disability getting to the ICU, right? Whether there were disparities, problematic practices there as well. When it comes to vaccination rates, this is, again, US data, I apologize. I focused on the US context because it's what I'm familiar with. So the CDC has graphs to show that, and lots of data to show this is from December 2021 to February 2022. And what they found is that people with disabilities, and you can see different types of disabilities here, had lower vaccination rates than people without disabilities. And so from this, they found that those with a disability had a lower likelihood of receiving the vaccination, despite being less likely to report hesitancy about getting vaccinated, because they studied that as well. So there can be a whole slew of barriers, many of which seem to have been preventable for persons with disabilities at the vaccination stage. And so given all this, here's the challenge. If standards of care and healthcare facility policies have to change in the course of a pandemic, right? If we can't stay in usual standards of care because we're forced into contingency standards, and we at least have to plan for crisis standards, because otherwise we're abnegating our responsibilities in that realm, right? There is a duty to plan in all this. How can healthcare systems avoid exacerbating vulnerabilities and inequities given structural injustices? That's totally easy to answer, right? It's complex. How can healthcare systems and individual providers prevent discrimination on the basis of disability? And how can we center disability perspectives in this crisis? So these are basically the three questions that my colleagues and I really focused on when we were writing our paper on disability rights and crisis standard of care frameworks. And we see different perspectives on like, what does justice mean in a pandemic? So this is one of, if not the most cited article about triage during COVID-19 is from the New England Journal of Medicine 2020 by Ezekiel Emanuel and colleagues. They say priority for limited resources should aim both at saving the most lives and at maximizing improvements in individuals' post-treatment length of life. So it's save the most lives and more life years or years of life is a consensus value across expert reports, right? That this is like public health ethics sort of 101 and public health emergencies. We saw lots of challenges to this notion, including very quickly from Ari Naiman, who is a disability activist. He also founded the Autism Self-Advocacy Network. And he published in the New York Times, by permitting clinicians to discriminate against those who require more resources, perhaps more lives would be saved. But the ranks of the survivors would look very different, biased towards those who have lacked disabilities before the pandemic. Equity would have been sacrificed in the name of efficiency. And so what's striking here is that both groups of authors, so to speak, they're using the word equity, but they're using the word equity in different ways here. So equity, according to Save the Most Lives or Life Years principle, is focused on maximizing total number of lives saved, which means focusing on the efficient use of resources and long-term survival. Right, this utilitarian calculus, I mean, Emanuel and his colleagues have said, it's not just utilitarianism that justifies this, it's other normative frameworks as well. But you know, part of the concern is how this can turn into a pretty brute utilitarian tool. Equity, according to disability rights, and I should have said this from the outset, disability rights activists and scholars are by no means a homogeneous or monolithic group. But what we see in the various things that have been written is that ensuring disabled people have the same chance of receiving maximum health care as their non-disabled peers is a key value. Right, so as Naiman said, it's looking at you know, sort of the ranks of survivors, and if disabled persons have been disproportionately affected by the pandemic and then denied resources to survive COVID-19, then that is a problem of justice. And so there's a focus on removing disability bias in many different layers of all the things and policies, having disability bias training, all sorts of different kinds of recommendations have been made, and providing more resources to disabled persons when they need it without viewing it as a waste. Okay. Words like waste are really powerful in a healthcare setting, right? And so this is part of the concern. And the Institute of Medicine, they have this vision statement for just care in a public health crisis that they published in 2010. And they identify 4 key values: fairness, equitable processes, community and provider engagement, education and communication, and the rule of law. So the idea is, in a pandemic, we should be cared about fairness to the highest degree possible. The standards, the guidelines that are used should be recognized as fair by all those affected by them. And they incorporate duties of compassion and care, responsible stewardship, and maintaining trust. Sorry, it's pausing. All right, equitable processes. They include values like transparency, consistency, proportionality, and accountability. Under community and provider engagement, education, and communication, they say active collaboration with the public and stakeholders. I'll add here, ideally proactive communication. Very, very, very few healthcare systems, at least in the US, ever reached out to disability groups before the pandemic. And then during the pandemic, they're like, well, we can't necessarily do that because we're trying to prevent a crisis over here. Right, but there are certainly opportunities to do it beforehand. And so values of inclusion and accessible and ethically responsible communication. The rule of law bit, I'll read here. The idea is to empower necessary and appropriate actions and interventions in a public health crisis, as well as the environment, to facilitate the implementation of crisis standards of care. So the idea with rule of law, very explicitly, I mean, there's no shying away from this, is to alleviate malpractice concerns for adapting to a pandemic. That certain kinds of standards of care, things that our Joint Commission or CMS would want in terms of like usual care, that when things have to be flexed, when certain resources have to be reused, when nursing ratios can't be what they normally are, that there won't be malpractice liability for that. And so our governors have to sort of declare a crisis standard of care can be implemented before it's understood that legally it's okay for hospitals to adjust in that way. So my colleagues and I asked several questions when it comes to disability rights and these four elements of the vision statement. Has there really been, or can there be, or will there be attention to increased vulnerabilities of disabled persons in relation to sickness, transmission, death, or other consequences? Has there been proactive planning with intersectional inclusion of disabled perspectives, so avoiding things like tokenism and understanding how ableism, racism, sexism, heterosexism, et cetera, can overlap and be part of the rich lived experiences of persons with disabilities? Has there been engagement with disability community about contingency and crisis standards? And again, there's been more of a push, especially when there are certain lulls in this pandemic, to talk about including persons with disabilities or disability groups and talking about crisis standards of care, but contingency standards of care, I've not heard that discussed nearly as much. Is there a prioritization of long-term care and home and community-based services caregivers for PPE and worker protections? There was a huge lag that was inexcusable at the beginning of the pandemic in the US. Has there been training on disability bias for these triage teams, these folks who are going to be trying to figure out who ought to be prioritized? Has there been appropriate accommodations and accessibility for communicating with disabled persons? Even in New York, a lot of the Governor Cuomo's like daily news conferences, they didn't have any kind of accessibility for persons who are hard of hearing or deaf, for example, right? So that's a huge problem. Has there been accountability systems for those in power to ensure consistent and fair decision-making? Are visitation restrictions not putting disabled persons at increased risk? Is there preservation of anti-discrimination laws and expectations, even though we understand that standards of care have to flex and that we shouldn't be suing nurses into the ground for that. At the same time, we have to protect anti-discrimination laws. And are there protocols for, say, ombudspersons to continue to monitor facilities? This was a big problem where people who were ensuring that like nursing homes were still safe, they just stopped checking on nursing homes during the pandemic because there weren't protocols for that. And so dangerous places like nursing homes became more and more and more dangerous with fewer levers for accountability. Oh, all right, so I'm going to pause so that we can talk. If we have time to talk about clinical policies and interact, great. If we spend the rest of our time just chatting, then that's perfectly fine with me as well.
Okay, great. Well, thank you so much, Dr. Guidry-Grimes, for your very interesting presentation. So we'll take some questions now, and I'll be keeping an eye on the chat if you prefer to express yourself in that way. So feel free to raise your hand, or it's a small group to just interact.
Yeah, I mean, I'd be happy to hear your perspectives on any of these issues, ways in which you think the Canadian context perhaps differed for better or for worse from the US context, your own ideas about, ways to think about recovery in terms of disability justice.
Yeah. Okay. Well, Marie Carpentier. Yeah.
Thank you very much for the presentation. I don't know if I'm moving forward to the next step of the presentation, but my question is very practical. Does your recommendation is to move from triage protocol? And I'm wondering, should we use non-clinical criterion in those protocols? Is that what you're saying?
So that was not what I was trying to say, actually. I mean, so yeah, I mean,
just to explain, I'm trying to figure out what kind of in these kinds of protocols we have to have criterion to pick and choose, because we move from a need-based decisions to like a contingency decisions we have to make with like scarce resources. So we have to make, so on what should we base our decisions then?
Yeah, that's a great question, and that is a little bit what I was gonna cover in the next section. But I would say that there have been some different proposals for how to incorporate equity considerations into triage protocols. So one thing is that when we think about prognostic indicators, right, we talk about saving the most lives or most life years. We figure out, okay, that value, right, it's not like unimportant, right, that we're trying to prevent excess mortality. But then what does that look like in terms of the thing that hospitals are going to turn to? And so overwhelmingly in adult populations, hospitals have been turning to SOFA, the sequential organ failure assessment. And SOFA is like terrible for lots and lots and lots of reasons. And so, I mean, it's really tragic that it took until this pandemic for us to realize the ways in which SOFA is deeply flawed. It overestimates mortality risk for Black patients. And there are lots of problems with patients who have like neurocognitive disabilities, where the SOFA score can sort of miscompute what their mortality risk is because of how the Glasgow Coma Scale is calculated, if it's not fixed, right, by a human, right, and not just pumped out by an electronic medical record. And so there are lots of issues with how we predict mortality, what actual mechanism we use. There are some hospitals that have recommended looking at like long-term mortality, like 5 years. Like if someone's going to die within 5 years, then they would be deprioritized at a certain stage. But we know that prognosis gets increasingly uncertain the more that we go out, right? Even 6 months, right? Where doctors are wrong all the time when they say someone's going to die within 6 months, right? It's very, very hard to prognosticate well. And when you talk with people with disabilities, you hear stories like, yeah, they told me I was dying, that I was terminal 3 years ago, right? And so there's also an overestimation of mortality risk with persons with disabilities, just because of what clinicians are trained to see and what they're not trained to see or think about. And so I would say that for one, we need to focus on very short-term mortality, like can they survive this hospitalization kind of metrics, which are more certain, which is more what clinicians are used to looking at, which are perhaps less prone to disability bias if we do it well. Another recommendation that has less to do perhaps with disability itself, but I think may help lots of persons with disabilities, is looking at like area deprivation index as a way to fix certain kinds of scoring systems, so that we have that equity fix. Some disability rights groups have said that we should just focus on a lottery system or first come, first serve. I'm not a fan of those as like the only response. I think that would lead to way excess mortality. So that is a very long-winded answer to your question, but those are some of the immediate thoughts. And exclusion criteria, right? When it comes, like a lot of triage protocols had particular disabilities in their exclusion criteria. And so I'll show that later if we have time. For example, in Alabama, if someone had an intellectual disability, they are automatically disqualified from receiving scarce critical care resources. So that's just, I mean, that's a consensus value at this point, that exclusion criterion is a big problem, and quality of life assessment should not be part of these triage protocols at all. Because, yeah.
Okay, thank you.
Yeah.
Thank you. Next, we have Haley.
Hi, thank you so much for this presentation. It's not really a question, but more a comment and a thank you, because 2 years ago was the day that this was named a global pandemic. And that was a day that was met with so much fear for me, because I live with cystic fibrosis and I had a liver transplant. So the pandemic, like I'm very familiar with the resources in the hospital system even before. And from the moment that happened, like being someone who lives with a disability, I was immediately afraid of resources just completely not being available to me for my acute and chronic care, but also because, God forbid, we got to a situation where I was super sick and needed a ventilator. I don't think I was going to be given one, given my lung disease. So I just wanted to say thank you for doing this research, and thank you for speaking about it, because it is a topic that I think a lot of people who haven't been faced with don't even think of. And especially the part about being isolated in hospital during the pandemic, obviously that was completely understandable, but I spent 12 weeks in 2020 in a hospital room by myself without any support from family or friends. So I just think it's really important that we keep talking about this and that people hear about all the different sides of it, because there's so much more work we can do for the next time something of this nature happens. And it will in the future. It might not be our generation, hopefully not, but thank you. I just wanted to say thanks.
Well, thank you for sharing part of your story there, and yeah, for lending your perspective. I mean, what I'm really, I have hopeful days and I have cynical days. On hopeful days, I think that there's been more momentum behind paying attention to the experiences of disabled persons than there has been, like in my recent memory. And that I really hope that this carries us into, you know, more proactive planning, more inclusive decision-making, and that we really fix lots of things that are broken, that we go down that path. On cynical days, I worry that when things turn, you know, become a lull again, right, that people will slip into the complacency again. And so we need folks like the folks on this call to keep carrying the torch.
That's what I came to law school for. So that's what I'm going to do.
Fantastic.
Richard?
Well, thank you so much for this presentation to this point. My question might be a little bit vague and a little bit uninformed, but I'll try my best to put my perspective forward. At the university, we faced a situation where protocols were put into place for return to teaching and return to the classroom that many of us felt were not taking into account you know, the needs and concerns of those with disability. And in particular, you know, the situation of those who are immunocompromised in various ways felt was not, you know, was not being taken into account adequately with return to teaching. I just wondered, you know, to what extent the notion that disability is sort of at the core of relating to the pandemic is something that might be considered. As I was listening to you, I had the sense, perhaps wrongly, that you know, we think about the pandemic as having potential impacts also on people with disability, as opposed to thinking, as I started to do when I was relating to the problem of immunocompromise, that in fact those who were sort of most directly in harm's way, or most likely to feel the brunt of the pandemic, were those who faced, at least some of those people were people who faced disability. Is that a good way of thinking about it, or a bad way of thinking about it? I mean, I'm trying to map into your presentation, you know, the significance of, and I've seen some of the statistics, the significance of immunocompromise in particular to severe forms of COVID and indeed long COVID and the like.
Yeah, so you let me know if I'm responding on point to you. So I'll say, first of all, when it comes to like schools, and even in the US, as I know in Canada, there have been great debates about masks, right? About mask mandates and everything. And, you know, when people justify things like lifting public health measures, the response is to look at aggregate data, right? Which is completely missing the point that, right, we should be caring for the most vulnerable. And I would have hoped that we had learned that better over the last 2 years, but I'm quite dismayed by a lot of the moves to lift public health measures when that's clearly not in the interest of people who are most vulnerable. And so, yeah, I mean, I think that this pandemic has, I would say decimated, but that might be actually an understatement in some cases. You know, the people who just generally are the most vulnerable in our society, people with certain kinds of disabilities, have been very, very much at risk, as you say. Congregate care facilities, I mean, this has been an area of disability activism way before the pandemic, right? And it's tragic that it took a pandemic for like national news outlets to have sustained attention to the dangers of congregate care facilities and the ways in which we need improvements. Even prisons. I mean, prisons were just, a place of terror for so many folks in this pandemic, where you have people who are already stripped of so many rights, who then are denied lots of care and exposed to lots of increased infection risk. And in Arkansas, I mean, you can Google it. I mean, we have lots of terrible cases in Arkansas prisons of what was done to prisoners. So, and then older adults might not be as obvious as a vulnerable population to a lot of folks, unless you really study, right? If you do age studies and whatnot. But of course, we know that lots of older adults were particularly susceptible to infection, morbidity, and death. And so, yeah, I mean, I think if we really shift ourselves, I mean, there was this slogan that we heard over and over and over again, that we're all in this together. And we're all in this together is a really nice phrase. It's painted on a side of a hospital that I drive by every day. And the problem with that is we're not all affected the same. And we've shown the great fissures in our solidarity as a local community and nationally and globally. And so I think if we do frame the pandemic as a way in which vulnerabilities that pre-exist are going to be exacerbated with catastrophic consequences, I think that that's a better way of approaching it, because every time we look at aggregate data, we're missing, I think, a lot of the point clinically and ethically. So I don't know if that really quite responds to you, but let me know.
No, thank you. It does indeed, and it did feel to me like this was very much a question about how we were dealing with those who are the most vulnerable, and that the choices that we were making were often, characterized as choices about what would maximize my own freedom or what would maximize my own comfort. Whereas, the impacts of my decisions on others who are vulnerable were not really taken into account. I'll just say a last thing about this. I mean, I was frankly shocked at my own university at being told by their legal counsel that there was no issue of disability when it came to requiring people to be together in classrooms, without verifying vaccination and so on. Whereas it was a matter of discrimination if we would force people to be vaccinated. So this kind of imbalance struck me as revealing a great deal about our relationship to disability altogether.
Yeah, absolutely. I completely agree and share your concern. And I really appreciate something that Dr. Beaudry, you said up front, that discrimination law and the ethical side of this too, of course, requires balancing equity and utility. When liberty interests get thrown into the mix, those aren't unimportant, but at the same time, if there's a focus on utility and liberty, then equity gets completely lost in the mix, for sure.
And when I thought about that again, when I saw your slide contrasting the two different meanings of equity, one, so I don't remember the slide exactly, but one being associated perhaps with disability communities arguments or legal arguments, and one being associated with the utilitarian or medical view, and the latter being taking equity to mean something like impartiality. And perhaps in law, we are used to making a difference, but in ethics as well, between substantial equality and formal equality. So treating people equally or treating them as equals. And so, so that's what I think that's the conceptual insight that disability scholars and or people launching lawsuits on the basis of the ADA in the States or here just writing to ministers, that's the point they were making. And some of them were successful in having the naming of certain disabilities, like intellectual disabilities here in Quebec, taken out of the protocol. None is, so I don't recall if it was a criterion of exclusion or a criterion that would give you a lower ranking when you would afterward be evaluated. I don't recall that, but it was a criterion, and then it was taken out.
Yeah, and the US, the mechanism that was used is that our Department of Health and Human Services has an Office of Civil Rights. And so disability groups would file these formal complaints at the federal level with OCR, with the Office of Civil Rights. And so then OCR would investigate and work with hospitals or healthcare systems or states, depending on where the protocol came from, to try to make certain fixes. And Ari Naiman, actually, whom I mentioned, he was actually hired by HHS at one point to help, sort through the different kinds of concerns to, have a good expert response to concerns about disability discrimination. So, yeah.
Okay. Okay. Well, are there any more questions? If not, perhaps I'll leave it to Dr. Guidry-Grimes if you want to have a few concluding words. Otherwise, I'll just proceed to thanking you. But was there something you wanted to add to conclude the meeting?
So what I'll do is I'll put my personal website in the chat, and this isn't for obnoxious reasons, or I don't mean it for obnoxious reasons, but it's in case anyone's interested in the slides, I will post them there. And I'll also have my updated contact information and would love to continue the conversation with folks. And one of the, when it comes to policies to consider, so of course there are triage policies, but I'll just mention that something that came up in contingency standards of care relates to physicians' concerns about potentially inappropriate or futile treatment in the context of a pandemic. And so the Michael Hickson case that I alluded to earlier, this really sad case where you had a Black man with quadriplegia who had total blindness after an anoxic brain injury a few years ago. I mean, he was subjected to what looks like, so I don't know all the details, it's a legal case that's ongoing, but what looks like informal triage on the basis of disability status. And that the video that I was going to show, it's publicly available. It's a Black video, but that's because the patient's wife recorded a conversation with the physician where the physician explicitly says that he thinks that they need to not intubate and continue ventilation and move the patient out of the ICU and move into hospice because of the patient's poor quality of life because of his quadriplegia.
Okay.
Yeah, so it's I mean, that's one of those policies that exist in usual standards of care that can have particularly onerous, dangerous, worrying overtones during contingency standards of care as well, where you have clinicians counting the ICU beds and are getting worried about that. And we should be worried about how many ICU beds we have, but we also worry about quality of life assessments running amok in the process. So that's what I'd say for folks who are interested in the law and policy on this is an area where I think insights from folks like you with your expertise would be really great for us to think about in usual as well as contingency standards of care. Okay, great. Well, thank you so much, Dr. Guidry-Grimes. And I just wanted to repeat that your website is www.lauradg.com, just in case if people listen to the recording but don't see the chat. Yes. Okay, so great. Well, thanks everyone for coming. And thank you so much, Sharon Webb, for organizing everything. And we will see you at some other events organized by the Center for Human Rights and Legal Pluralism. Thank you so much.